Thank you, a privilege, and thank you for the invitation to Rod and Udi and Jens. I think this topic is mildly controversial, and I think particularly in ivory towers, there is this standing on ceremony that you absolutely need a diagnosis to treat. And I think it puts people, particularly in community hospitals, at a real disadvantage in having to figure out things on the fly in a patient who's neurologically compromised. And so I want to make the argument that potentially we do not need a diagnosis in the setting of a person with an unknown primary, no known diagnosis of cancer and myelopathy. Here's a 53-year-old football coach who presented with high-grade cord compression, significant myelopathy, lower extremity weakness, and numbness requiring ambulation with a walker, and has no known diagnosis. And you can see this T10 lytic destructive disease with high-grade cord compression T1011, again, presenting with a significant myelopathy in the middle of the night. The differential on this tumor is it can well be a synchronous solid tumor without knowing that he had particularly tumors such as renal cell, non-small cell, or breast. And I don't think anybody would argue that in the setting of a solid tumor malignancy with myelopathy, according to the Patchell study, that should be taken to surgery. The hematologic malignancies, many people will say you should never take a myeloma, lymphoma to surgery in lieu of the response to chemo and radiation therapy, with perhaps the exception of a gross spinal instability, which often is at presentation with myeloma. So I think many people would argue for radiation therapy. And then the primary tumors, chordoma, chondrosarcoma, the argument is made that all of those patients need an en bloc resection, or you ruin the chance to give them tumor control and long-term durable control. In the GNOMES framework, as Ilya so wonderfully presented, if you know the radiosensitivity of the tumor, you can predict the response to therapy. So for the sensitive and moderately sensitive tumors with high-grade cord compression, we're very comfortable treating those patients on high-dose steroids with conventional external beam radiation, 30 gray and 10 fractions. For moderately to highly resistant tumors, with high-grade cord compression, those patients typically we take to separation surgery and then followed by radiosurgery to get local tumor control. The change comes when a patient comes in with high-grade cord compressions, actually myelopathic, and truthfully, we're only comfortable treating patients with really significantly sensitive tumors, a myeloma, lymphoma, with conventional external beam radiation, and the remainder of the tumors, including those moderately sensitive tumors, prostate and breast, are now candidates for separation surgery followed by radiosurgery. That's based, again, largely on the Patchell study, as Ilya described, published Lancet 2005, prospective randomized trial looking at high-grade cord compression with myelopathy, comparing surgery and conventional external to conventional external beam radiation alone. And in every outcome variable, surgery was better than radiation therapy. So if we come back to that situation now of having high-grade cord compression with myelopathy, how do we justify taking those truly radiosensitive tumors, myeloma and lymphoma, to surgery? And I think the argument is really twofold. We know that we can get a great response if we know the tumor histology. And Ilya showed you this slide of a patient with myeloma who got 3 gray times 10, tumor completely apoptosed, decompressed in the spinal cord and recovering neurologic function. The problem is it's very hard to definitively get a diagnosis, particularly in the middle of the night, with a needle biopsy, and often takes several days to get a diagnosis before you can definitively make a recommendation based on tumor histology. Here's a patient who came with significant sclerotic bone disease and high-grade cord compression. For all the world, this looks like lymphoma. I think most of us would have called it that. We got a touch prep biopsy that showed small blue cells consistent with lymphoma. We gave equivalent of conventional external beam radiation therapy. 2 days later, the flow cytometry came back with no abnormal B or T cells. And even with that, occasionally we'll see these tumors come back as lymphoma. And then 10 days later, it came back as a neuroblastic tumor, a completely radio-resistant tumor histology. And you can see what happened. We re-imaged this at a month. This patient happened not to be myelopathic, but had high-grade cord compression. And they basically had no response and no decompression to conventional external beam radiation. So I would argue that it's very difficult, even in a tertiary cancer center where they look at these cells all the time, look at tumors, and are willing to make calls on these tumors. We got this one wrong, and that's not infrequent. It takes days to get a definitive diagnosis, and then you may well be wrong that it wasn't myeloma lymphoma, but something truly radioresistant. And the second issue is really that once somebody develops myelopathy, they often fall off the cliff. So they don't have a gradual decline in neurologic function, but even on high-dose steroids, they can fall straight off the cliff. We have an experience where we often will transfer patients in who are myelopathic, and it takes 2 days to get clearance and then another day to clear them once they're here. And oftentimes we've seen those patients acutely decline. And so I think when there's an opportunity to treat that patient when they're neurologically in good shape, you have a much better chance of preserving neurologic function and getting recovery. And so in those patients who come in myelopathic, regardless of the tumor histology, whether it's a solid tumor malignancy versus hematologic, I think you're justified in taking that patient to surgery. A, it's the safest way to get them decompressed, and B, you're going to preserve or recover neurologic function the vast majority of the time over guessing that it's a radiosensitive tumor, and you're going to get an apoptotic decompression. By the grace of goodness, we no longer have to do these massive surgeries for this patient population. It used to be in the old days that we would do a front back or a 360 to get these patients decompressed into surgery. Now with separation surgery, the two fundamental goals in terms of the decompression are met together. One is spinal cord decompression for neurologic preservation. And the other is, again, what we're really trying to do with this surgery is decompress the spinal cord to create a better target for radiation. And then the additional is to put a screw rod system in. And by the grace of goodness, everybody who does spine surgery in this day and age can virtually put screw rod system in and do this really simple decompression to get patients out of trouble and get them as candidates for radiosurgery if it turns out to be a solid tumor malignancy. Ilya showed you this beautifully. Separation surgery is a very simple technique. Traditionally, we went 2 levels above and below the index level. We took a high-speed drill, drilled off the lamina pedicle facet joint, found normal dural margins and stripped the tumor off of the dura, and then took out the PLL to affect a margin on the anterior dura. And really what we're trying to do, again, is just reconstitute the thecal sac, decompress the spinal cord for neurologic salvage, and to get a better target for radiation. And this technique has become even more simplified. Again, traditionally, we went 2 levels above and below the index level, such as here. This was a single-level renal cell with some epidural disease, and yet we went 2 above and 3 below to get fixation. And now, as just described, with cement augmentation of these PMMA-augmented fenestrated screws, we can now go short segment and overcome the 2 big issues of adjacent segment progression or osteoporosis and hold these patients well. When we use long constructs, we had a 2.8% failure rate that required a reoperation. And now with this short segment fixation, it's about the same at a 2.2% fixation failure rate. And so, again, we're making the separation surgery shorter and better. We just got a transfer in from another hospital that presented with high-grade cord compression and myelopathy. And I think this construct is gaining traction. They came in with short segment PMMA augmented screws and an excellent separation surgery that we can then target for radiosurgery. In terms of our outcomes from separation surgery, 75% of our non-ambulatory, the myelopathic patients, regain the ability to walk, and overall 90% were ambulatory. And in terms of patient-reported outcomes, they do significantly well in pain and general activity. Now, what becomes important, I think, particularly as patients live longer, and then you start to delve into the area of the primary tumors, is really whether this strategy gives you durable tumor control. This was the original series we published of 186 patients looking at separation surgery followed by radiosurgery for principally high-grade cord compression with radio-resistant tumor histologies. And in point of fact, 50% had failed prior radiation. And in the high-dose single fraction or high-dose hypofractionated radiation, we had less than 10% recurrence. We now have looked at renal cell carcinoma, again, one of the most radio-resistant tumors to conventional external beam radiation, using this strategy of separation surgery followed by radiosurgery. And in this series, the 1 and 2 year progression-free survival were 95% at 1 year. And then we lost a little bit of control, but not much at 2 years with 92% control. And then again, with non-small cell lung cancer, again, considered markedly radio-resistant to conventional external beam radiation using a median dose of 27 gray in 3 fractions. again, our 2-year progression-free survival was 95%. So we get superb local tumor control with this radiation. The question is, does that begin to impact how we approach those patients with high-grade cord compression and myelopathy with chordoma? And I'll go back to that patient that we presented at the beginning, this 53-year-old football coach who presented with high-grade cord compression and myelopathy and was actually using a walker. And this was taken to surgery for separation surgery at an outside hospital. One of our very good friends in Connecticut did this separation surgery 2 levels above and below the index level and decompressed the spinal cord to the point that the patient got neurologic recovery. And there are many in the audience who potentially say, you have completely ruined the chance to get a cure on this patient by not doing an en bloc resection. And I would argue, again, that this patient was neurologically compromised, and the best strategy is get them out of trouble by doing a decompressive surgery. The reason you can't do an en bloc for wider marginal margins in chordoma is really, it's precluded by anatomy in the spine. One is high-grade cord compression, where your dural margins you cannot clear. And then in the cervical spine, you obviously have other issues like vertebral artery and these large paraspinal tumors that go into the esophagus, abut the esophagus and the pharynx. And so there's a lot of reasons that in high-grade cord compression and a lot of chordomas that you cannot do an en bloc resection to get margins. It turns out that chordomas, like these solid tumor malignancies that metastasize, are actually remarkably sensitive to high-dose radiation, both conventionally fractionated radiation, and now we know we have very good outcomes with stereotactic radiosurgery. There are a number of ways to deliver this high-dose radiation using conventionally fractionated proton beam or carbon ions, and then this high-dose hypofractionated using stereotactic radiosurgery or photon beam radiation. We showed this last year, but one of our first cases where we got the sense of how radiosensitive these were to single fraction radiation was this patient with chordoma who came in, who was unresectable based on medical comorbidities, got 24 grade single fraction at 4 months, went into intralesional resect the tumor for what we thought was progression and was 99.9% necrotic. So these are remarkably radiosensitive to radiosurgery. And in that series of 35 patients that we've recently looked at with de novo chordoma, the mobile spine and sacrum, half were in the mobile spine, half in the sacrum. Surgery was done as definitive radiation in a third of the patients. A third of the patients got no surgery, but radiation only. A third got intralesional, either the separation surgery or curettage gross total. And then a third in the sacrum underwent en bloc resection. And again, the radiation was given as neoadjuvant, and a third definitive, no surgery at all, and a third an adjuvant postoperative, and a third. And when we gave 24 gray single fraction, the recurrence-free survival rate was 90% at 24 gray single fraction. And again, it didn't matter whether they got it as definitive radiation, intralesional, either separation surgery or gross total, or en bloc, and as a postoperative adjuvant. The only thing that was meaningful was the dose of radiation at 24 gray. We had 90% local control. In terms of complications, obviously the biggest complication is en bloc sacrectomy with loss of bowel and bladder function. And then from the radiation standpoint, most of the grade 3 toxicities were imminently fixable, with the exception of one treatment-related secondary malignancy, or rhabdomyosarcoma, in the radiation port. So we go back again to this patient who had this chordoma at T1011 with high-grade cord compression. And again, this argument has been made that we have mandated this patient to no cure by doing an intralesional resection. In point of fact, the decompression they did was excellent for neurologic recovery, but not good enough to give 24 gray single fraction, which we think is ablative. So we took him back for a reseparation surgery and reconstituted the thecal sac to create a better target for the radiation, then gave 24 gray single fraction. The other issue we had was this is a very good construct for metastatic disease, but in somebody who's going to live a long time, we really need good bone graft and then a more solid construct. And so we went back, oversized the screws, cement augmented all the screws, did a vertebroplasty at the index level, and then took a vascularized rib graft and rotated it posterior lateral fusion, and then took autologous graft from the crest and put it on the contralateral side. Here's a 2-year follow-up film where you can again see that we have completely ablated this tumor with radiation. We've decompressed him. We gave him neurologic recovery. We gave him a construct that should be durable for life. And then we gave him radiation to get local tumor control. And at least at the 2-year follow-up, it's been remarkably good. If you look at this patient with a high cervical myelopathy and high-grade cord compression with bilateral vertebral artery disease, again, not a candidate for en-bloc resection to potentially cure this patient. And we did a simple separation surgery followed by 24 gray single fraction. Here's reconstitution of the thecal sac at 24 gray single fraction. The 7-year follow-up film shows no evidence of tumor. So in some way, again, especially in the patients who have high-grade cord compression or myelopathic, you really need to figure out a strategy that gets them out of neurologic trouble and then get a target for radiation where we think we can give an ablative dose of radiation. In chordoma, there are other strategies that are coming into play. There are multiple immunotherapy trials that may impact both local tumor control and maybe this abscopal effect where we get in patients with distant metastases. And Josh Yamada, who's going to speak next, is is absolutely the pioneer and genius in so much of what we do here. But this was a patient with a very similar tumor to chordoma. This is renal cell, but like chordoma, has a lot of PD-L1 receptors. She'd been twice irradiated and failed. He irradiated only the center core of this tumor, 27 gray and 3, but patient was maintained on dual checkpoint inhibitors. And over the course of 2 months, the tumor completely disappeared, apoptosed, and was not visualized on the perfusion imaging, which we use to look at the viability of tumor. So the combination of checkpoint inhibitors and radiation may allow us to treat bigger volume tumors at lower doses, staying within constraints of organs at risk, and still getting this meaningfully impactful treatment effect. So I would encourage you on the patients with high-grade cord compression, again, that you don't really need to know the diagnosis. Even if it's myeloma, lymphoma, you're justified taking them to surgery because you can get that patient out of trouble acutely and then get them to effective therapy. And in chordoma, you have not ruined the chance to get a cure if you can follow it up with meaningful adjuvant therapy. Thank you very much.
As always, fantastic, Mark. Privileged to hear from you and learn from you. Really amazing stuff. So the question that I have again is, you really were circumspect and thoughtful in pointing out the issues of community practice and the contrast to the ivory tower hybris, which we frequently can be kind of targeted with. So radiosensitivity of lesions is one of those really big decision-making points. Where are we beyond our own kind of encyclopedic knowledge in kind of predicting whether something is going to be radiosensitive or not in this first wee hours of the morning, Thursday, Friday night holiday assessment of a patient?
You know, I think I think histologies drive radiosensitivity diagnosis. So if you know definitively the tumor histology, simply based on that, you can predict the tumor response. And I think myeloma, lymphoma are universally radiosensitive. They're also remarkably chemosensitive. So even sometimes with high-grade cord compression, even with myelopathy, they'll go straight to systemic therapy. Our experience with prostate and breast cancer is that they're remarkably radiosensitive. They do respond to conventional external beam radiation. But in the setting of myelopathy, you don't get that apoptotic decompression, that immediate resolution of the epidural disease, no effective immediate decompression. And so in those patients, even though they are radiosensitive, they're not radiosensitive enough to actually give you a decompression. There's a lot being worked on in the genomic landscape to predict the radio responsiveness, particularly to conventional external beam radiation. I think it's really theoretically really interesting, but in the acute setting of myelopathy, for example, for non-small cell lung cancer, there is a predictor of radiation response, but that's a 10-day workup to get that genetic test back, and so it's not really feasible in the acute setting. But people are working on that.
Hey, Mark, that was terrific. This is Rod. So on that patient that had the, separation surgery and then ended up having chordoma, what's the timing of radiation? And, do you wait 3 months? Do you wait 6 weeks?
Yeah. So in essence, the power of radiosurgery, as sort of Ilya alluded to, is that you can do operative corridor sparing radiation. And so the vast majority, especially in the metastatic domain, are going to radiation within 10 to 12 days of the surgery with no penalty to the wound. And so we go really as quickly as we can get a plan together, we'll go to radiation. And I would say that would include chordoma. But chordoma usually is a little more indolent. And so you probably don't have that time element that you have for something like a prostate cancer, which if you wait a month, it will be back and bigger and more compressive. And so I think there is timing to that. If you're going to use proton beam, at least standard proton beam, you probably need to wait at least 4 to 6 weeks for wound healing, because there's a massive amount of radiation that goes through the back of the wound. And maybe Josh can address this, but with pencil beam protons, there's more wound sparing potentially than there used to be. So there may be an avenue to give protons post-operatively, but we're pretty wedded in chordoma to 24 gray, and with that we can do very good wound sparing. So we'll typically go as early as we can.
And then one last question is, what about, there's this whole new push now. What do you think about the fixation, like titanium versus, different material for fixation and radiation? Do you think that makes a difference?
It does. I think, it goes both ends of the spectrum. I think cobalt chromium, we looked at it, and there was a 9% shielding on photon radiation, so we never use that. Titanium, there's not a great penalty for stereotactic radiosurgery, so we use that certainly in the metastatic population most often. And I think the recent discussion with Josh and our group is that if we have recurrent tumor after radiosurgery, and they're going to go to a proton beam, or for all primary tumors, we're now pretty wedded to peak with the ability, again, to give proton beam radiation with no penalty, where with titanium, there's a significant issue with that. So that's kind of our strategy now. We use peak. It's very expensive, obviously, but we use it pretty judiciously, mostly when we're going to proton beam as a post-op adjuvant.
Great. Thanks, Mark. Excellent talk.
Thanks so much.
Dr. Mendel, do you want to ask any final questions to Dr. Bilsky?
Can I make one comment there, Jens, about the...
Larry, hey. Dr. Rines.
I think one other thing to add to Mark's comments, and I don't know what Josh's opinion on this will be. I think there's two issues with the implant choice. One is, as Mark was alluding to, is the shielding, the dose deposition, particularly for heavy particles being affected by the material. And we've known that for many years. There's been issues trying to combine protons, for example, with titanium. I think the other issue that's not negligible is vision for the radiation oncologists. I think in order to deliver, whether it's with protons or, as Mark was talking about, the SBRT, spinal radiosurgery, I think the ability to deliver the kind of doses that you need to effectively treat a chordoma is obviously reliant on having an experienced radiation oncologist, but also reliant on having a radiation oncologist able to discriminate where is the tumor and where is the cord. My experience with the radiation oncologists is that, when there's uncertainty, the default is be safe and underdose if you're not sure about the anatomy, where's the tumor, where's the cord. So I think consideration for some of these alternative materials is not just driven by the impact on the dose and backscatter and dose deposition, but also driven by the better our radiation oncologist can see where is tumor and where is cord, the more certain they'll be and confident they'll be that they're not causing any harm. And that may actually also drive improved dosing. And that is, I think, critically important for histologies like chordoma, which are generally radio-resistant tumors. I mean, the doses, you may be able to overcome that with 24 gray in a single fraction, but not if you don't know where that 24 gray in a single fraction is going and you're dose trimming in areas of uncertainty. So I think it's a two-factor issue that makes the radiation maybe more effective based on the choice of the implant material.
Josh, you want to address that? It is very important, Larry. Thanks for for bringing that up. Go ahead.
Yeah, good morning. I really appreciate Larry's comments as well as Mark's comments. I think it really underscores the importance of having a multidisciplinary approach to these complicated problems, because as we strive to integrate improvements in all aspects of cancer care, including taking advantage of multi-parametric MRI imaging and incorporating that, look at radiogenomics, and how that's going to impact how we treat our patients. To Larry's point about having optimal conditions for utilizing these imaging tools, it's really going to be, I think, increasingly important in the future that we don't have any kind of unnecessary interference or difficulties with the amount of data that we can collect from these imaging tools. So like Carbon Peak, I think is going to become an increasingly important part as we try to integrate these new technologies and trying to personalize cancer care. Because imaging is, I think, always going to be an important part of managing these spine tumors. So, things like that are going to be increasingly important. I'll talk a little bit about protons, but there's no question that it can have a significant detriment, especially as you're trying to cover around the pedicles. Very difficult to do without introducing a lot of lateral beams for protons, which takes away some of the significant dosimetric advantages of proton beam therapy. And so, although these are evolving techniques, I think, working in a multidisciplinary manner to map out and plan how to optimize care for each of our patients is really the key. And having these kinds of thoughts and thinking about it together, I think this is a great example of why you have to do that.
Larry, I think the other thing that's really interesting, just we've been talking about a lot too, and really led by Josh, is that we use myelogram CT, for post-op treatment planning, and the dye, the contrast is now not available as we have a week supply left. So we do focal MR, which is pretty good at really getting around metallic artifact, and it's been a godsend. Correct me if I'm wrong, Josh, but now that we don't have dye, it may be that Peak is a solution to imaging until we resolve that issue, which is really something we've never had to deal with.
And to your point, Mark, if we get really good at doing this with MR Sim and gain experience with that, there's a potential to avoid the myelogram. And we do it, routinely for all these cases that are instrumented, but it is an additional procedure for every patient. It's an invasive procedure. And so if we're in a position to make strides that avoid that, that's to the patient's benefit as well, I think.
Brilliant, yeah.
Yeah, and it's also important as you follow up these patients and make sure, and without having to worry about any kind of imaging artifact, it's also, I think, key because we watch these patients very closely, and often there's a lot of uncertainty just because of the imaging artifact and what's going on.
I want to drive home on that in a second, Dr. Yamada. Whilst we have both of you live, Dr. Bilsky and Dr. Yamada, fantastic constellation, by the way, and Dr. Rines, Dr. Yang has asked one more time, because it's such an important paradigm shift. If we have a known chordoma patient, do we no longer have to really try to shoot for an en bloc resection as long as we can deliver an adequate radiation dose? So can you just re-emphasize that point? Maybe we'll start with Dr. Bilsky, then hit Dr. Yamada, and then Dr. Rines in that sequence.
I personally think it's a work in evolution. I think the one specific issue that we were talking about today was high-grade cord compression myelopathy, where you cannot do an en bloc resection to get margins on that tumor the vast majority of the time. And, you don't want to wait for a diagnosis or to get them transferred to another institution to get set up for an en bloc resection, potentially for somebody to try to get margins, that we can salvage those patients potentially with high-dose conformal radiation. I think the rest of the integration of radiation is a work in evolution. There is a tremendous amount of data on surgery, some of which may not have been quite as good as we would have prayed it was. And then there is an infinite amount of data on radiation that, at least as surgeons, we don't really take into account. And the data on protons, carbon ions, and photons in multiple iterations has shown to be incredibly effective. And I think it's really incumbent on us to figure out how to meaningfully integrate that. In our own institution, we are very active, especially in older, sicker patients who cannot tolerate a big surgery, at doing radiation and then following them and then making decisions down the line because the morbidity is just too prohibitive. So I think it's a work in evolution. We're pretty wedded to it, and we're really working hard to define parameters. But, I don't think we can definitively say one way or the other. I do think in high-grade cord compression in the middle of the night with myelopathy, that I'm pretty definitive on. I don't think you need to try to do some heroic thing that has no hope of giving you control. And we're really good with radiation as an adjuvant.
Do you share that confidence, Dr. Yamada?
Yeah, absolutely. I think there's some situations where, for example, like if you have a low sacral chordoma that can be, very readily unblocked, that there's those kinds of situations, the patient probably won't benefit from any kind of adjuvant radiation, and those patients recover from surgery quite well. But you also have to take into account the potential morbidity of an en bloc resection in the mobile spine, for example. We've had an experience where we have a number of patients who we would treat with neoadjuvant radiosurgery. And those patients, for example, a high sacral chordoma, even though the radiosurgery was planned as a neoadjuvant into definitive resection, many of those patients, once they see the results of radiosurgery, they start feeling better. They will decline a high sacrectomy because of potential morbidity. And we will tell the patients, we don't know whether definitive radiosurgery is going to actually give you the same rate of cure as a high sacrectomy, en bloc sacrectomy, but the patients don't care because, quality of life issues are equally important to them. So it is case by case. And we certainly, I don't think we have enough long-term data to say that radiosurgery can replace intralesional surgery in every instance, but like Mark was saying, there are a lot of instances where you don't have a choice. And radiosurgery seems to be a very good salvage in those situations. We certainly wouldn't say that radiosurgery completely replaces en bloc resection, but there are so many instances where patients are not eligible for a curative en bloc anyways. In those cases, radiosurgery in combination with surgery, we think is likely to provide equally high probabilities of tumor control as an en bloc, and particularly helpful for patients who are never eligible for an en bloc resection. But as Dr. Bilsky was saying, this is something that's evolving as we're gaining greater experience. And we just need to get longer follow-up on our patients to be able to say things that are more definitive than that.
Larry, you're one of the heroes of en bloc resections and amazing reconstructions. Is that era coming to a close as Dr. Yamada's insights change the treatment options?
Yeah, I would answer that with a couple of points. First of all, I congratulate Mark and Josh for really pioneering new and potentially less invasive ways to get to the same point for these patients, which is to get them cured and do that in a way that minimizes morbidity as much as possible. That's what we all want. And if you're a surgeon who does these en bloc resections and you look at your results, as many centers have reported, and see that even with perfect en bloc resection, local recurrence rates are in the 30 to 40% range, you got to be scratching your head and saying, what can I do that improves the situation? And so I think we're all trying to do better. But I do think the data is still not clear. I think for the heavy particle radiation that has been traditionally used, the morbidity of those therapies is also very clear and can be very devastating. And you can have complications that are worse than the actual disease. And we still don't know when we see a patient a priori who's the patient that's going to do well with an en bloc resection alone and who needs the extra radiation. So to commit everybody to a potentially harmful treatment when many will not need it is not ideal either. So I think it is a work in progress for all of us. As I said, I applaud Mark and Josh for, pushing this forward. It's important to recognize that the studies still have limited numbers, as is always the case with these Chordoma studies. If you break down the data and look at 30 patients, individual subsets will have different things done. If you go back and look at the MGH proton data, it's not a uniform treatment for every patient. So I think we need to continue to try different things and to study it and get longer term follow-up. I also agree with what was said is there's different cases. The case of spinal cord compression with circumferential disease, you're just never going to get an en bloc resection in that case. And so that's a patient where you need to come up with some other plan and maybe, separation surgery followed by radiosurgery is the best way to do it. But to me, if you see a lesion that is resectable in en bloc fashion and it can be done with limited morbidity to the patient, I still think that's the gold standard. I don't think there has been anything that has been proven to be better than that. And I think we're still waiting for that data. I think Mark and Josh both said it well. It's an iterative process. We need to understand if we're going to use separation surgery followed by radiosurgery, what specifically we're doing. Is it only work with 24 gray in a single fraction? How wide a margin do you need to treat the residual disease with? How do you cover microscopic disease that's in that penumbra outside of these things to me are still unclear, and many centers don't even do 24 gray in a single fraction. So what's going to happen when they do separation surgery for a chordoma? So, been a little long-winded here and covered many points, but I think what I would say is applaud you guys for pushing the envelope as you always do. I think anybody who looks at our results critically will recognize that we need to do better. The systemic therapies also need to be included, but I think we're just at the beginning. The numbers aren't enough yet to say one is better than the other. Certainly there'll be certain circumstances where one approach is better than the other, but I would not say that en bloc resection has been has faded out. I still think it's the gold standard for tumors where an en bloc resection is feasible and where the morbidity is understood by both the surgeon and communicated well to the patients, and that the patients understand what the potential morbidity of their surgery is before the surgery is undertaken.
So excellent. Such a privilege to have all stars like you here. And I want to recognize the well over 100 participants that we have. There are 80 on direct stream and over 100 in Facebook Live around the world, literally. And I want to particularly shout out to several colleagues that I see from the Ukraine. We're with you in thoughts, and we're honored to have you with us. Thank you for your interest. Dr. Mendel, Dr. Yamada has been introduced several times now.